So we're on time. I think we're a couple of minutes early. Our next session is a year in review. So we're going to have several of our AOCA members are going to join us and give snapshot sessions of anesthesia subspecialties, and I'm going to give you a brief introduction to each of the folks. I think we'll just go through all of them, and then if you can hold your questions until the end, unless each person wants to take those right away, but hold your questions till the end, as we'll have a panel, so please write down your questions for each of these subspecialists. So we'll start with, first we're going to hear from Dr. Hargrave, Jennifer Hargrave, who she is an associate professor at Cleveland Clinic Lerner College of Medicine and the current Department of Cardiothoracic Anesthesiology, Vice Chair of Education in the Cardiothoracic Division there. And she's also the Fellowship Program Director. After Dr. Hargrave, we'll hear from Rafal Kopansik. He's an anesthesiologist intensivist at Ohio State at the Wexner Medical Center. Then after that, we'll be joined by Dr. Suzanne Huffnagel, clinical professor of anesthesiology and obstetrics and gynecology at Thomas and Jefferson University, and she subspecializes in obstetric anesthesiology. Then we'll have Dr. Michael Fabro, who's done a great job with this conference, so we appreciate that. He is a professor appointment at the University of Miami and serves as Chief of Cardiac Anesthesia Services, and he's Medical Director of the Perioperative Service Department there. Then Dr. Jessica Geller, who's our Associate Professor of Anesthesiology at the University of Nebraska at the Medical Center, Clinical Service Chief of Pediatric Anesthesia, and she leads as a Director of Perioperative Services at Children's Hospital and the Medical Center. And then we are hearing from Dr. Ashley Bailey Klassen, who she's quadruple board certified in interventional pain management, and she currently practices at Trinity Interventional Pain and Spine Clinic. Lastly, we're going to be joined by Dr. Michelle Dariani, a board certified anesthesiologist and intensivist at UPMC Pinnacle. So with that, we have amazing specialists here. So I'd like to turn it over to Dr. Hargrave to begin this portion of the afternoon conference.
Thank you so much, Rob. And I know my topic may be a little bit different than updates. We're actually going to look backwards a little bit at history and see what we can decide how that helps drive our future direction. But I want to jump in on this, and I'll just say thank you to the program committee who made room for me. I asked for a little bit of time because I think you'll find this interesting, and I found it interesting as I have thought about this over the years, did some research here and there, and kind of tried to drive a little bit more in the last few weeks as I was preparing. I'll tell you that was interesting. As I was preparing this lecture, I ran into several different discussions of crisis of identity. And I think that we can all say that it seems like in our society we have many crises of identity, perhaps crisis identity regarding your profession, your education, your just well-being, just who you are. There's many different crises out there that individuals are dealing with. And I have to say, when I was thinking about it, the medical profession, and maybe even I could say the specialty of anesthesiology, has had some crises of identities throughout the year. So let's think about that and think about how our profession was able to continue to evolve and develop and continue to grow during some of these crises of identities. And maybe it will help us understand where we want to go in the future. So let's think for a moment about the history of modern anesthesia. Many of us are aware of sort of the timelines, and we're going to walk through several timelines here today. But let's start out talking about the first time that anesthesia sort of became something used in the medical profession, and that was in 1842. William Clark, he was a medical student at the University of Rochester, and he began to try to experiment. Actually, he left the university, he was back home, he was helping one of his sister's friends who needed a tooth extraction, and he used ether to cause a state of unconsciousness and have that tooth be extracted. That was soon followed by a sort of low-profile experiment that Dr. Crawford Wilson Long did. Dr. Long will talk about here in just a moment, but he used ether for a cyst removal. And Dr. Long was a little bit cautious regarding what he did, and he didn't really want to publish it until he had a cohort that he thought was reasonable to introduce to the medical community. Just a little bit about Crawford Wilson Long. You can see that he was a graduate of the University of Pennsylvania, but he was from the South, and he returned to the South. He actually practiced in rural Georgia. He wasn't among the medical elite on the East Coast and in some of the Ivy League institutions. And so he sort of, again, was low profile. He experimented with an unconscious state using ether, did a rather involved extraction of some sebaceous cyst, and had success with that. And there's a picture you can see, that I found that was very interesting. It actually is in the UT Health library, medical library there, that Pat Nixon is named after her. But he was actually well recognized, and it was considered. He's considered one of the founders of medical interventions in America. He was on the first postage stamp. Doctor's Day was named after him. And as I said, he kept a low profile for a few years as he tried this and tried to determine if it would be helpful for patients. Now, although ether was sort of the initial introduction into an anesthetic state, nitrous oxide was becoming something to be considered. The rich and the famous were having their nitrous oxide parties and having these states of lower consciousness, and a dentist by the name of Dr. Wells decided perhaps that would be helpful to cause patients to have less pain during some procedures. And he came to MDH with the ideal of anesthetizing a patient with nitrous oxide. Well, the problem was that the patient wasn't anesthetized enough. There's still pain associated with nitrous oxide. It's not a very good analgesic. And the patient cried out, and that caused quite a bit of controversy, and Dr. Wells was shamed by the medical community. Unfortunately, he actually ended up taking his own life after several years of not being recognized for what he was doing and being considered a medical professional. Dr. Morton then joins the scene, and Dr. Morton was also a dentist. He did have some physician and dentistry was a little bit more blended then than it was now. So this was back in 1846. This was in October. It was back in March that Dr. Long was involved. And Dr. Morton then gave the very famous ether dome experiment, in which he used ether at Mass General to demonstrate that surgery could be performed by that. And this is the famous painting that we all are familiar of and seen throughout our careers. Well, there was a lot of debate between Dr. Long and Dr. Morton, and we can talk more about that later on. But on the across the pond, anesthesia was also gaining some grounds, and not necessarily by anesthesiologists, by some of the obstetrical and obstetricians, such as Dr. Simpson. In 1847, he was using chloroform to help provide some analgesia during labor and delivery, and it was made famous and perhaps socially acceptable a few years later when Queen Victoria requested chloroform during 2 different births that she had. And Dr. John Snow was the anesthetist for that. And Dr. Snow, I'll just say just an interesting note about him. I mean, he is well known for his work in epidemiology and identifying the chloria location in London, but also extremely recognized as just an outstanding physician and contributor to medicine. But anesthesiology and anesthesia still had a little bit of a crisis of recognition. And I appreciated this historical piece that was published a few years ago that talked about the steps of establishing a profession. And I'm going to read this. I know it's a bit long, but it points out some of the weaknesses of our specialty. Anesthesiology began as a craft or a trade rather than a true profession. It was associated with surgery and dentistry, which at the time neither technically facilitated nor systematic, or had neither technical facilities or the systematic scientific underpinnings to be considered professional. There was a lot of drama around anesthesia. The early years of the anesthesia history in the United States were blemished in its petty scrabbles and rivalries about who should be credited for the discovery of surgical anesthesia. There was an inadequate attention to scientific principles and unsafe practices. Very high doses of nitrous oxide, so there was sort of a negative component to the profession. So anesthesiology was also lacking other important elements of professionalism: standards of care, innovations, clinical science, rigorous educational programs, and professional organizations to discover and disseminate information. So it's rather interesting that this profession, this historical piece said, look, the anesthesia was a little helter-skelter all over the place, and until you could start developing your societies and your educational programs, you really lose some of the ability to say that you are a profession or a professional. Well, anesthesia caught on to this, although this was a retrospective piece, but they began to understand this in the late 1800s, and it was in 1893 that the London Society of Anesthetists was formed. And this was interesting. I mean, you didn't really sign up to be an anesthetist. Oftentimes you were a surgeon who perhaps wasn't recognized for their technical abilities, and you were sort of an underling or an understudy, and you were trying to gain more recognition from the surgeon, so you would be the anesthetist. Sometimes this would be delegated to nurses, but it was sort of difficult, and it really wasn't truly recognized as a profession on its own. 1907 was when the first United States Anesthetist Society was formed. That was Long Island, and that later became known as the New York Society of Anesthetists, and we'll sort of talk about why that's important in a moment. But in 1902, a Chicago anesthetist or anesthesiologist, as he preferred to be called, began to be vocal about the ideal that we need to move past the technician role. So Dr. Cypher is known for and recognized for saying for the first time there's a study of anesthesia, anesthesiology, and an anesthesiologist is how we should be considered, not just technicians as anesthetists, but really an anesthesiologist who is a scientific authority on anesthesia and other anesthetics. Well, the societies have been created. We've sort of said we need to move into a role in which we have scientific contributions, and education is the next step to that. Well, it was 1927 that the University of Wisconsin formed the Department of Anesthesia. It was recognized that Dr. Ralph Milton Walters, was the individual behind that, and one of the things that he was responsible for was creating one of the first residency and formal training programs in anesthesia. He trained several recognized anesthesiologists. As you can, Dr. Rovenstein became involved a little bit with him, and Dr. Rovenstein in 1935 started the famous Bellevue Hospital training program. Also, Dr. Rovenstein said, hey, we need a location where we disseminate our information and our scientific findings. And that's when the PGA was created. Everyone is aware of the Postgraduate Assembly in Anesthesiology, the one that takes place in New York every year, still to this day very popular, and that was his work. In addition, one of Dr. Walter's trainees began to come to the New York area, and Dr. Virginia Apgar went to Columbia University, first director of anesthesia and an anesthesiologist there. One of the things about Dr. Walters, though, that's sad, especially considering that Dr. Apgar was his protege, is that he made a very strong statement, and several times made statements that women should be avoided and not be allowed in the profession. He said they're just not fit for this profession, and it's sad to hear that, because Dr. Apgar's contributions and role will be in medicine for centuries to come. So to think about. Well, societies began to form, and I know we're still talking relatively early in the practice of medicine, as that is organized medicine as we know it. But in 1936, the New York Society expanded. It became the American Society of Anesthetists, and eventually became the American Society of Anesthesiologists. There was a board the American Board of Anesthesiology, and it stayed under, and this was Dr. Rovenstein's sort of build out and working towards separating the certification for anesthesiologists from the surgeons, and it worked. It was under the surgeons, and we'll see here in just a few moments that's sort of a similar pathway even for osteopathic anesthesiologists. So it was 1940 in which the ABA was formed and had its own independent status. Okay, so that's the specialty of anesthesia and anesthesiology and how that was formed. But osteopathic medicine, is there a place for anesthesiologists in that role? If we remember the teachings and sort of the initial work of Dr. Still, he was very focused on self-healing. He was skeptical of some of the surgical practices of the day, and probably rightfully so, because many of those were barbaric in nature. And his focus was to do his very best to include and introduce self-healing. But as osteopathy and osteopathic medicine began to grow and osteopathic hospitals were created, surgical services were needed because there are definitely, and we know that it's on a daily basis, times in which individuals require surgery. So surgeons were needed, and if you have surgeons to perform surgery, anesthesiologists become very valuable and an essential component of your practice. So I want to talk for just a moment about some of the history of osteopathic anesthesia and the challenge of sort of establishing a situation. And we'll talk for just a few moments, in a few moments, about the certification process and just the recognition of osteopathic specialists. But here's a timeline to look at. In 1892, Dr. Still has the first school in Kirksville. In 1927, so it's still now 50 years after Dr. Still has started the American School of Osteopathy. It's 1927 before the Society and the American College of Osteopathic Surgery is formed. So our colleagues at the ACOS, it took several years for them to be able to sort of lobby and say, look, we are osteopathic physicians, but we are specialists in the area of surgery, and we need this role in our hospitals. We can see the timeline I mentioned before, in 1936, where the ASA was formed, in 1940, where the ABA was formed, and that became independent. But right in that time, we began to see the establishment of the first Society of Osteopathic Anesthesiologists, the American Society of Osteopathic Anesthesiologists. Dr. Hallett, he was the one who sort of led the charge. He had several individuals in Detroit join with him, and they actually had a joint meeting with the American College of Osteopathic Surgery later in 1950, a year after they first established. I don't know a lot about the SOA, but I can tell you that a number of the individuals who were involved in founding that organization later became presidents of the ACOA, or the AOCA. There was a sort of a transition over. And we'll talk about why in just a moment. But we can see here just some of the pictures of some of the very well-known individuals that we've seen throughout the records of our own college and the contributions that they've provided. I was very curious. If you look at this list, there actually is a Dr. Marshall, Dr. Amanda Marshall, listed here, and I looked through everything I could find, including Ancestry.com, looking for obituaries, looking for anything I could find information about her. Was not able to, but I was very curious because it is not often that you see a woman anesthesiologist listed in such a list of individuals involved in an organization at this time, and so I'll keep looking and try to find out more, but I'm curious. And it was interesting, and in the AOCA documents I couldn't find any acknowledgement of her really later participation. Well, in 1949, as I mentioned, the American Society of Osteopathic Anesthesiologists was formed, and in 1950 the AOA, the American Osteopathic Association, recognized this society as an affiliate. And Dr. Esterline was very involved in this, and of having an affiliate status, and began to continue to ask for development of this area. We can see that the same year that the ABA was formed and became independent was actually when the Osteopathic Board of Surgery began to give exams for our own osteopathic anesthesiologist. Training was, and we'll talk about this here in a moment, but it was very difficult. If you were an osteopath, you weren't able to oftentimes even have credentialing at an allopathic hospital. So it became very essential that the osteopathic community create their own examination and educational programs to grow the necessity for caring for their patients. We've heard about Dr. Esterline in the past. Jeremy is very fluent, and he gave a wonderful presentation on him a few years ago. But just a brief breakdown of the contributions that Dr. Esterline provided. Graduated from the Kirksville College in 1933. He actually married one of the Still daughters. So Dr. Elizabeth Still, she was a physician, one of the early women physicians of our society. He interned at Laughlin Hospital, which I brought back some memories, because every day as I would walk to my undergrad, I went to Truman University in Kirksville for my undergrad, and I'd walk past that hospital every day as I was going to the Science Hall. He studied anesthesiology at the McKinnon Group, and it was quite common because there weren't formalized training programs. You would do an apprenticeship with a group that performed and offered something in your specialty. And he was well known as a founding member of the Osteopathic Board of Anesthesiology, and I'll give credit and want to give credit to the Museum of Osteopathic Medicine, where we've worked with Jason and had great work with him, but a number of these pictures came from there. But I have to say, I think Dr. Esterline must have been quite the character. Every picture I had seemed like he was either involved with smiling, laughing, or some type of practical joke. So probably a very interesting and delightful individual to be around. So in 1950, that's when the AOA recognized affiliate status. But the organization realized that it needed to step it up. It needed to provide some fellowship abilities to be able to offer fellowship distinctions, as we did last night, but it also wanted its own training programs. And so it wanted to move from a society to a formalized college, and that's the pathway within the AOA. And that was something that was very important to continue. And in 1952 was when it happened. Now, I mentioned very briefly that certification for anesthesia was actually not on its own, neither for the allopathic community for a period of time. It was 1940 before the ABA was formed, but it was very similar in the osteopathic world. The American Osteopathic Board of Surgery, they were the ones that certified anesthesiologists, and this was actually the letter that was sent to the board to say, by a surgeon in Kirksville, to say, Dr. Esterline, we think he does a nice job with his anesthetics. We think you should consider him for board certification, and that we think he's a competent individual. And it was a surgeon writing that, so it's very interesting. But that did not last for very long, because in 1956, the AOBA was formed, and certification now was determined and provided by anesthesiologists. It was a set-alone board under the AOA. So if you see, it's not that long ago. It's really not that many years ago that we see that such large and dramatic steps happened in history. Well, we talked a little bit about establishing the challenge of establishment and establishing a profession, but I want to talk for just a moment about the educational environment over the years for osteopathic graduates. In the 1920s, most osteopathic graduates had to remain within osteopathic hospitals. They were sent out, it started out more initially primary care, sent out into communities. Hospitals would be established. And then at that point in time, they were the hospitals that were training the osteopathic grads. You didn't have the option of going into an allopathic training program. If you can see here, it was 1966, and it was almost 20 years of hard work to allow osteopathic physicians to practice in the military. They kept having to go back to the military and say, look at our medical school training, look at the training that we had as clinicians throughout the years, and we should be able to practice. And it took many rounds of going back and forth. But finally in 1966, DOs were allowed to practice in all states, or allowed to practice in the military. In 1973, DOs were finally allowed to practice in every state in the United States. That is not that long ago. We need to remember how much work it was to establish our profession, and be grateful, especially for those who've spent time working in that field. You can see, as far as it also in the allopathic world became important to establish pathways. In 1972, the Liaison for Graduate Medical Education was established to try to create some form of standards among training programs, and that evolved into what is now today the ACGME, and that was established in 1981. Well, I mentioned the importance of education, and so I just wanted to highlight a few individuals that I began to find out as much as I could, sometimes not a lot, but this is one name that was very popular, or will be recognized by many who trained at Kirksville. Dr. Marinelli, as you can see here, was chair of several different hospitals, was military based, but also was a long-term and very dedicated educator at the Kirksville College of Osteopathic Medicine Anesthesia Residency Training Program. And another image I was able to obtain from the Osteopathic Museum there, and he's sitting in the middle with the glasses on. Dr. Ponce, we talked about just briefly last night as far as fellow in the American College of Osteopathic Anesthesiologist. He graduated from Kirksville, but he did not stay in Kirksville. Actually became an educator at Art Center Hospital in Detroit, later became Michigan Osteopathic Medical Center, was very closely involved with Michigan State University and the Osteopathic College there, but also just a great contributor to many of the individuals who trained in the Michigan region. And then the individual who introduced me to anesthesia was Dr. Butterworth. She was a graduate of the Kansas City College of Osteopathic Medicine. She began an anesthesia residency there. She completed her anesthesiology residency at Osteopathic Hospital, began teaching very early on in the Kansas City training programs, became a professor of anesthesia and chairman of the Department of Anesthesiology at the University Hospital associated with KCUMB. So a few highlights of educators that are recognized for training many of us, or at least introducing us to anesthesia in the osteopathic community. Well, I mentioned it was 1973 before individuals had a chance to practice in all 50 states, but just to let you know a little bit of things that have changed even more recently than that, it took until 2001 for Louisiana being the final state to allow the MBOE and recognizing that exam. So that was allowing DOs now to be licensed in all 50 states. And then in 2015, there was a merger between the Osteopathic Graduate Medical Education Council and the ACGME. So all programs are now accredited and trained under one educational and standards committee. So let me ask, are we currently in a crisis of identity? Perhaps, I don't think so, but I have to say we've seen over and over again how we've been asked as a profession to change with society. I know that there was some disappointment when the American Osteopathic College of Anesthesia was no longer engaged with some of the training programs, but I'll still contend today we are engaged. We're just engaged in perhaps a different way. So everything old potentially is new again. One thing that I will say when I walked away from this, I realized now how important societies and colleges and boards were and are in establishing the fact that you are a competent individual. And so I think it's really important that we continue to support all of those organizations that really help to fight for us and validate our professionalism. You could see as you walked through the various different arms that I spoke about how important it is to have education involved. And I just want to challenge everyone to teach. If you want someone to remember your contributions, teach. And maybe it's residents, maybe it's the scrub techs, maybe it's the respiratory therapists, maybe it's just, it doesn't matter. Anyone that you have a chance to share medical knowledge with, certainly that's one of the most powerful ways to establish who you are and the competence that you bring as an anesthesiologist, as a professional. I think advocate for the competency that we bring as anesthesiologists and demonstrate the perioperative care that we bring. I mentioned when speaking with the ASA president-elect that I recently talked to a very young junior anesthesiologist, actually just out in practice a few weeks ago, in the last few months. And he was very upset because he's struggling with the crisis of identity because he's gone into a practice where he's basically been told, your job is to value the cRNAs, be sure that the cRNAs stay with us, send them, get them out, make them, they can go home, they go home early, you stay late and cover for them, finish their cases, etc. And it's all because of finances. It's all about the way the model that entity can remain solvent is to therefore be able to provide anesthetic care at the least cost possible. And so it's a little bit of a crisis of identity, but I talked with them and I said, I don't have perfect answers for you, but these are the things I will tell you to do. And really especially demonstrate. We have to demonstrate as a profession that we bring value to caring for patients. Well, I'll contend here as I close that we do have the elements of a profession as anesthesiologists, as osteopathic anesthesiologists, and even in this day and age where identity crises surround us. We were challenged by areas in which our profession in years past has not been able to really meet the criteria of professionalism, but we have met it now. And I think that we need to advocate for that. I will just give a very brief reminder here that we need to fight to provide the opportunities of others. It's becoming more challenging to become an osteopathic anesthesiologist, and there are challenges. So every opportunity we have to mentor medical students, to be on selection committees at our institutions, anything that we can do to help provide for the opportunity of the next generation is really a strong legacy that we can leave. So with that, I will close, and I appreciate the opportunity to share that with you. Dr. Kapanchik, I believe, is coming up next, so thank you.
All right, good afternoon, everybody. Thank you for having me again. It's always a pleasure to join you in this beautiful venue. And today my job is to give you a quick update about critical care over the last year. So these are my disclosures, which are none. I'm still working hard on them, and nobody's lining up just yet. So maybe after today, somebody will. And these are our learning objectives. And today, I'm going to make it easy for us. We're just going to talk about one paper that came out over the last year, as it's going to impact your practice the most as generalists. So, namely, we're going to talk about the new definition of acute respiratory distress syndrome. So this is an updated definition that came out just a couple of months ago. And given the fact that you will be taking care of patients with hypoxemia at some point in your career, this is going to be a great way to actually go into what has changed. So what is the actual rationale behind coming up with these with the new definition? So last one that we've had is called the Berlin criteria, and that was in 2012. And since then, we have quite a few things that changed. And we're going to go over all of them exactly, but just as a quick note, we've been using more heated high flow nasal cannulas. We've kind of been using SpO2s a little bit more often. We've been using lung ultrasonography. And for all these reasons, we are changing our definitions. So before we actually head into the definition component, let's talk about history, since we had a wonderful presentation today from Dr. Wunsch about the start of polyepidemic and how that resulted in mechanical ventilation. This kind of follows very clearly and nearly to that development. So as soon as we were able to intubate and mechanically ventilate, we've started noticing patients developing acute inflammatory response that somehow caused issues with the lungs. So at first, after heart surgery, patients would have hypoxemia, and people would call it some sort of a congestive atelectasis or a response to a bypass machine. And then in 1967, the first paper came out that was describing what we now call acute respiratory distress syndrome, or ARDS. So in 1967, 12 patients were described to have tachypnea, hypoxemia, and loss of compliance. And these patients were located in Denver, and actually, shout out to my institution, the first author was from OSU, actually. So we had 12 patients that were described to have these inklings of now what we consider actual definition of ARDS. And just as a note, there were 7 patients who suffered severe trauma. 4 patients suffered a viral pneumonia, and 1 had acute pancreatitis. So that was the patient population, and authors in this particular paper described that the disease resembled infantile respiratory distress. And they also noticed that PEEP did help in certain patient populations and that corticosteroids helped in certain patient population. So that was the first paper that put respiratory distress, as they called it at the time, on the horizon. And for the next couple decades, nothing has changed. Obviously, people were describing this disease process more and more, but there was no clear definition. So that changed in 1988 when a group of physicians came out with the first definition of ARDS. And they, at first, described lung injury score. So they kind of tried to put severity to the disease, and they used oxygenation, and in particular, they used the PaO2 to FiO2 ratio. They used the chest X-ray, PEEP, and the decrease in static compliance. So this is now called a Murray score because it was written by, the first author was Murray. But whoever does ECMO will know that Murray score is still being used by physicians who deal with ARDS and VV ECMO. But in addition to that, they defined ARDS based on chronicity. So they also noticed that chronicity is an issue, severity of disease is an issue, and then what is the cause? So all that went into the first definition that these people suggested, but it wasn't agreed upon. It wasn't until 4 years later where ATS and the European Critical Care Society came out with the first true consensus definition. So let's take a look at it. What did they actually talk about? So first, they described 2 different entities. They described acute lung injury and then actual ARDS. Okay, and how did they differ? The difference was in the oxygenation level. The ALI, or acute lung injury, was anything under 300 but more than 200 when you have the PaO2 to FiO2 ratio. And then everything under 200 was ARDS. But in addition to that, we then described timing. So acute onset was one of the necessities. Then oxygenation we already talked about. Then chest radiograph. We had to have bilateral infiltrates that were seen on the chest X-ray. And then the last component was an actual swan with the wedge pressure. And that thing was pretty much telling you, is there a cardiac component to these bilateral infiltrates? So if you were less than 18, that meant that the heart was doing fine and the heart is not the cause of those infiltrates. So that's why at that time we had the wedge pressure included in the definition. All right, so that was all nice and good for another 2 decades until Berlin criteria in 2012, okay? So what happened in 2012? So first, few things stayed the same. So timing is, again, acute in onset, but we actually put time on it. So we gave it 1 week. If you had some sort of a weird disease, sepsis, injury, what have you, that was 1 week or less, you satisfied that particular part of the definition. Then you had chest imaging. So again, bilateral infiltrates that are not being caused by, let's say, an effusion. If you can't oxygenate because you have a bunch of volume pressing on your lung, that's not ARDS, right? Or if you have just collapse of your lung or bad atelectasis that is not caused by an inflammatory process, that's not going to count either. Then edema. So we took away the swans out of the equation because at that point we have already proven that we should not be putting swans in everybody. So we had to take the number 18 from the wedge pressure out of the equation and just say that the edema cannot be cardiac in origin. Okay, so that's where that comes from. And then finally, we gave severity to our oxygenation issues. So acute lung injury became mild ARDS. The ratio between 100 and 200 became moderate, and then everything under 100 became severe. Okay, so that's the definition that you will probably still be using, and most people will be thinking about for the next probably few months, 2 years. until the new definition comes into play. So, what happened since 2012? So first thing, we've been using heated high-flow nasal cannula. So it's a little different than the regular nasal cannula. This little thing, you can put the prongs in, crank it up liters from 30 to 60, which actually provides you a little bit of PEEP and helps with the oxygenation. And we've actually shown in that trial for Raleigh in 2015 that if you use heated high-flow nasal cannula, you will have improved outcomes at 90 days and less intubated people at 28 days. So somehow we have to include that now into our ARDS component. And then during COVID, we've been using heated high-flow on many people, right? So we've learned that you do not need to be intubated in order to be diagnosed with ARDS. Until this point, by the book, a patient cannot have ARDS if they're not intubated, which makes no sense, right? What else happened? We've started using pulse oximetry, and we validated the pulse oximetry in our severity of ARDS. So instead of using PA to FiO2 ratio, now we've shown that actually using SpO2 to FiO2 ratio also works, okay? Then lung ultrasonography became a thing. So instead of maybe doing an X-ray, if you can show that you have bilateral B lines in both lungs that are associated with congestion and not heart failure, you can use that over an X-ray. And finally, all that is well and good if you're working in a resource-rich environment. But what if you're somewhere else where you do not have a ventilator? Or if you don't have an ABG machine? Right? What if you don't have an X-ray machine? Like, how do you diagnose somebody with ARDS in a resource-limited environment? So in 2016, a group came out and suggested the Kigali modification criteria. So they still kept the 1 week. They obviously then said that instead of PaO2, we should use SpO2 to FiO2 ratio. There should not be any PEEP requirement for the places where there is no ventilator. And then use of ultrasonography if you have it. And personally, I practiced in Kenyan ICU for a month, and there wasn't an ultrasound machine there. So it was actually much easier than to order an X-ray and much cheaper. So some places out there do have ultrasounds available that you'd be surprised even at the resource-poor environments. But we did not put any arc lines in. We didn't put any central lines in. We just put an EJs in everybody. So those are real concerns for resource-poor environments. So with all these things in mind, 32 clinicians got together and they've held virtual meetings, and over a year they came up with new definitions. So let's go over their global definition of ARDS. So ARDS is an acute diffuse inflammatory lung injury. So we know that again. That occurs due to anything, injury, sepsis, infection, what have you. Any diffuse inflammatory lung disease where your body responds poorly to the damage that something caused. And we have the predisposing factors of pneumonia, non-pulmonary infection, trauma, transfusion burn. We all know that. And this injury leads to pulmonary, vascular, and epithelial permeability, meaning leaky vessels, okay? And then that contributes to atelectasis and loss of aerated lung tissue. And then the hallmark of that is going to be hypoxemia, diffuse radiographic opacities associated with increased shunting, alveolar dead space, and decreased lung compliance. So nothing new, really. We kind of understand that that's what it was. But now let's look at the actual things that are a little bit more new in this particular situation here. So again, the first part is going to be the origin of the edema. So the big problem with the previous definition is that, oh, we only are looking for edema that is non-cardiac in nature. But what if your patient comes in with EF of 20%, and by the definition, they might have a little bit of pulmonary edema, but they also have ARDS on top of it. So you can have heart failure and have ARDS at the same time. So they kind of say that here is that primarily it cannot be attributable to cardiogenic pulmonary edema, but patients can still have some pulmonary edema from the cardiogenic issue if that cannot be the main cause of the oxygenation problems. Okay, so that's a little change here. Timing, more or less, is the same. And the chest imaging here, they again stated that X-ray is not the only modality. Now we can also use lung ultrasonography if we show bilateral B lines and consolidations on the ultrasound. Okay? So that's the new addition to the definition. And now the biggest changes. So this is where you truly need to pay attention. Now we have 3 different ARDS categories. We have non-intubated ARDS, intubated ARDS, and modified definition for research variable settings. So now when you diagnose somebody with ARDS, you can say intubated ARDS, or non-intubated ARDS. And if you're in a resource poor environment, you can do something else. But so how is it different? So let's talk about non-intubated ARDS. So that means people on heated high flow nasal cannula or non-invasive positive pressure ventilation. Okay? So both of those count. So if, however, there are little caveats. If you're using heated high flow nasal cannula, your flow of liters per minute needs to be equal or greater than 30. So greater than equal than 30 liters per minute for your non-invasive heated high flow nasal cannula. And at the same time, if you do have an arterial line, your PaO2 to FiO2 ratio needs to be less than 300, or if you're using SpO2 to FiO2 ratio, less than 315. So that's new, okay? That hasn't been around before. SpO2 to FiO2 ratio is now in a definition, and it's less than 315 if you're non-intubated. And then finally, if you are on CPAP or BiPAP, you need to have at least 5 centimeters of water provided, okay? With the same values. Then intubated ARDS, it's pretty much all the same, except for the availability of diagnosing with SpO2 to FiO2 ratio. And those numbers are different, so a new thing to memorize. For mild, 315 through 235. For moderate, 235 through 148. And for severe, everything under 148. So those are new numbers. And then finally, if you're in a resource-poor environment and you can just go through the SpO2 to FiO2 ratio less than 315, and your SpO2 needs to be less than 97%. But then you do not need to have positive pressure, or PEEP or any sort to diagnose that, okay? So now let's give quick examples. We have a 68-year-old male with abdominal sepsis, and he's mechanically ventilated with FiO2 of 0.5, PaO2 of 75, and the PF ratio of 150. So by the book, that is now going to be called intubated ARDS, and the severity is going to be moderate. But what if we have a lady who's 54 years old and she has breast cancer and COVID pneumonia and worsening shortness of breath for the past 6 days? She's on heated high flow nasal cannula, 40 liters a minute, SpO2 of 91, and S to F ratio of 114. Now that we can call non-intubated ARDS, but no severity can be given, okay? And then finally, if we have a patient that's 39 years old with abdominal sepsis the patient is on a supplemental oxygen by face mask of 15 liters, FiO2 of 0.6, SpO2 of 85, and SpO2 to FiO2 ratio of 142, you can say ARDS in the research variable setting, okay? So that's a little update. So in summary, we have new global definition. Intubation is not required. But if you're not intubated, you have to be on heated high flow more than 30 liters per minute, or your CPAP or BiPAP more than 5, equal to 5. And then hypoxemia levels, still 300 if you're looking at actual arterial line tracings, but 315 if you're looking just at SpO2. Okay, bilateral opacities are the same, but now you can do an ultrasound if you are experienced in it. And then in resource-limited setting, you don't require PEEP, oxygen flow, or specific respiratory support devices. So now you can go out there and diagnose people with intubated or not intubated ARDS. All right, and thank you very much.
Okay, so what I'm going to talk about today is just a couple things that is relatively new, things that are relatively new in the OB anesthesia literature. I don't have any disclosures. These are my learning objectives. I'm going to talk about Sugammadex during pregnancy and lactation. I'm going to talk about anesthesia for second trimester D&E, and I'm going to talk about dexamethasone for post-op C-section pain. So the first thing, there is actually a SOAP consensus statement on Sugammadex use during pregnancy and lactation. It was an ad hoc task force, and those are the authors, they are SOAP members. As we all know, Sugammadex was approved in 2015. It's a gamma-cyclodextrin, and this is the structure. It has a hydrophilic oligosaccharide exterior and then a lipophilic core, and what it does is inactivates rocuronium and vecuronium by encapsulating the free molecule, and then forms a water-soluble complex that is renally excreted. There's no metabolism, and the half-life is 2 hours. If you have renal insufficiency, it just delays total body elimination, but it's not recommended for use in someone on dialysis. These are the doses for reversal, and it is, if you look at the Bridion pamphlet, these are actual body weight. And the incidence of anaphylaxis is really low, 0.03%. I've not had a case, but there was one presented here, a pediatric case. We also had a case at my institution. I wasn't involved in it, but one of my colleagues told me, and it was pretty bad anaphylaxis. What about Sugammadex use during pregnancy? Well, 4 milligrams per kilogram, which is that intermediate dose, reduces unbound progesterone by 34%. And progesterone is really important for endometrial growth to sustain early pregnancy. So what can we say about that? Well, there were some animal studies done where very large doses, 30 milligrams per kilogram, were done in rats and rabbits. And what did they find? In the rat studies, there were no effects on the duration of the pregnancy and no incidence of teratogenicity. Whereas with the rabbit studies, they did find a decrease in reduction of birth weight, and there were some teratogenic effects. So how do we extrapolate that to humans? Well, it's unknown. The literature is insufficient to evaluate whether there's problems with decreasing the progesterone levels or for teratogenicity. So this task force recommendation is, there was supposed to be a sound there. Oh well. To use traditional neuromuscular blockade reversal. And at or near term pregnancy, it's safe for the mom, but we're going to talk about baby in a second. So what about Sugammadex use in breastfeeding women? Sugammadex, a little bit can be excreted in breast milk, but the good thing is that it's a large molecule. It's hydrophilic, and it has a a short half-life and a low pKa. But things that cause or can cause increase in accumulation in breast milk are there's no protein binding at all, and the peak onset is going to be, if you used it and reversed it, mom who was having a section under general anesthesia, corresponds to the time when mom is usually trying to start suckling her infant. LactMed, which is a drugs and lactation database, and the European Medicines Agency consider Sugammadex to be safe during breastfeeding. But if a mom wants to discard breast milk, you don't need to wait 24 hours. In 14 hours, there's going to be less than 2.5% peak concentration. But what about the task force? What do they recommend? Oh, yay, now I got it. To use, again, traditional reversal agent therapy. And the main reason is that Sugammadex is not approved in, and I say pediatric, but I mean kids under 2 years, so in newborns. What about Sugammadex in childbearing women? Well, we talked about that decrease in progesterone, and that can be a problem for women that are using oral contraceptives. It's like taking a dose 12 hours late. So the recommendation is to use additional, like a barrier method, for 7 days if you've given it to a woman in childbearing age who is using oral contraceptives. So what does the task force say? Same thing, use traditional blockade when possible, but you should have a pre-op discussion with your patients because you might end up needing to use it, and so you need to talk to them ahead of time, and then if you do use it in one of these people that is on oral contraceptives, then talk to this woman and give her post-procedure counseling with some kind of suggested patient information. And this is just something from the article or the consensus statement. We have our own little blurb that comes up, we can print out off of our EPIC record, and it's better to give somebody this in writing rather than just telling them, because they're not going to remember what you said. Well, because the task force recommends neostigmine and glyco, is that even safe? So neostigmine is a large quaternary compound. It has a half-life of only 15 to 30 minutes. It's highly ionized in maternal plasma, so it can even evoke an oxytocin response, so it's very unlikely to pass to breast milk. What about glycopyrrolate? Again, it's still a large quaternary ammonium compound, and it has a short half-life as well. But long-term therapy can reduce lactation and reduce oxytocin secretion. However, we're just talking about a single dose here. So the task force says there's no adverse effect on breastfeeding, and it is approved in pediatric patients. Okay, next thing I'm going to talk about is anesthesia for second trimester D&E. Now, why is this an issue? Well, we've been getting some discussion from our OBs about wanting this, and what I'm talking about is deep sedation, and we're going to go over what the literature says. Now, the definition of deep sedation in an article that the OBs quote to us in Contraception in 2020 is directly from the ASA definition, in which patients may have purposeful movement to repeated or painful stimuli. Now, I say that's not what our OBs really want. What our OBs want is no movement. They really want general anesthesia. I mean, it's just semantics, but in my mind, deep sedation is not general, but we're going to let it go for now. But this is what their definition in this article that they're telling us, look at this is safe, but what they really want is general anesthesia. Well, there are some advantages. It avoids tracheal intubation complications, and these patients tend to have faster recovery. You don't have to wait as long for them to wake up and get the tube out. But again, the disadvantages are going to be the risk of pulmonary aspiration, especially we're talking second trimester, and certain other adverse events that I'm going to talk about in just a minute. So there were 3 studies that looked at aspiration risk. There was one in Journal of Clinical Anesthesia in 2011. There was one in Obstetrics and Gynecology in 2018, and then the most recent one is the Contraception article in 2020, which is the one that our OBs gave us and said, look at this. Well, there are some general points. These studies were all retrospective or meta-analyses. They were not randomized prospective studies. They looked at DNCs and D&Es up to 24 weeks, but they had some strict criteria. Now, this deep sedation was various agents used, midazolam, fentanyl, propofol, and ketamine, and I'm not going to go into the doses or what they used. These were all done at outpatient abortion centers. This is all what they did. They were healthy patients. They limited BMIs to under 40, and I mean, I still think 40 is a little bit on the higher side, but this is, again, something that you guys will make a decision about. These were all done by anesthesia attendings or CRNAs. There were no trainees involved in these patients. They were also strict adherence to NPO guidelines, and they were all elective cases. There were no emergency cases here. Now, they described different airways. There was a natural airway, oral airway, and LMA. Well, if an LMA was used, to me, that's general anesthesia. Again, semantics. There were some that got paracervical blocks and some did not. I used to think that it made a difference, but the studies didn't really bear that out. And they looked at, in combining all of these 3 studies, over 14,500 total patients. What did they find? In all these 3 studies combined, there were only 2 cases of aspiration. One ended up intubated in the ICU overnight, and one was admitted but not intubated. And then they had an incidence, so that gives you an incidence of up to 0.1%, which is pretty low. There were some other complications, 11 other complications in these 3 studies combined, including laryngospasm and stridor, seizures, hypotension, bradycardia, upper airway obstruction, and a case of lingual nerve injury. That gives you an incidence of 0.28%, again, quite low. So in conclusion, anesthesia-related complications are pretty rare doing deep sedation for second trimester D&Es. Pulmonary aspiration is even more rare. So, deep sedation for elective D&E in the second trimester in healthy patients is very safe in a community setting. Take this with a grain of salt. We are not, in my institution, a community setting. This is in the hospital. We have some of the patients that are there for reasons because they have too many health issues that can't be done in outpatient abortion centers. We're a residency training program. We have CA1s in those rooms. They are some larger patients. So again, you need to have clinical decision-making and discussions with your OBs as to whether you think it's safe or not. I have started doing some of these with, and I'm usually putting an LMA in because, again, it's not just, to me, deep sedation. It's a general anesthetic. And I've had pretty good luck. I only had one case where the woman had fairly bad asthma and just kept coughing on the LMA, and I had to paralyze her and put a tube in, and then give her a bronchodilator. And then, again, if I have someone in the holding area who's morbidly obese or is vomiting into a bag because of the doxycycline that she was given orally up in the spew, which is what they want, then I will say that's not happening here. But I've started doing this, and we do get through more of these in a shorter period of time. So I'll leave it to your judgment. Last thing I'm going to talk about is dexamethasone for post-op C-section pain. Now, dexamethasone has been used for post-operative pain for quite a while. A single dose can be used for adjunct post-op surgical pain, and there was a meta-analysis between 2011 and 2011 of randomized controlled trials that looked at over 2,700 patients. And what did they find? And this was in anesthesiology. They found decreased pain at rest and with movement. They found the higher dose, and their higher dose was 0.1 milligrams per kilogram. They showed reduced opioid consumption. There was no increase in infection or delayed wound healing, and there was no increase in blood sugar levels. They also found that pre-op administration gave better post-op pain relief than waiting till the end of the procedure. What about post-op C-section patients, which we're talking about? So there was a randomized prospective study. This was in IJOA in 2018. They looked at 52 patients, and they randomized them to either getting 8 milligrams of IV dexamethasone or placebo after delivery. They didn't give it prior to the procedure. And they showed decreased pain scores at rest and with movement 12 hours post-C-section. They did find a decrease in opioid consumption at 24 hours, but it was not statistically significant. It was only about 3 milligrams. And they did not find any increase in adverse events or neonatal blood sugar. Now, the very newest guidelines are a study that came out in the British Journal Anesthesia in 2022. This was a prospect guideline article that talks about different things that can be done to try to minimize post-op C-section pain, not just drug-related. That is the journal or the article. And what it did was it updated the literature, and it developed recommendations. And we'll go through them in a minute. But these were all studies from 2014 up to 2020, randomized controlled trials. They evaluated the effects of analgesic, anesthetic, and surgical interventions. So not just one of us. This is all of us together. These were all elective C-sections under neuraxial anesthesia. IV dexamethasone was given after delivery, and they looked at 4 randomized controlled trials. They did show better pain scores. They showed prolongation of analgesic effect. They showed reduction in opioid consumption, but again, I said from that other study, which is what they're quoting here, only by 3 milligrams, so it really was not statistically significant. They showed reduced need for post-op antiemetics, And they also said caution in patients with glucose intolerance. So I'm going to just go through what these recommendations are. That will finish my talk up. So the first one was, again, the reason for this is to minimize opioid prescriptions. So they recommend that you use neuraxial long-acting opiates like morphine or hydromorphone if you can. They also recommend prescribing non-steroidal anti-inflammatories or paracetamol here, which would be acetaminophen for us, on a regular basis, not just for a PRN basis after the C-section. And here is the recommendation for dexamethasone. A single dose of IV dexamethasone, and they don't say what, but the study that looked at it was 8 milligrams after delivery in the absence of contraindications has a very high recommendation, grade A. They also stated consider injection of wound infiltration or fascial plane blocks if you are not able to use neuraxial long-acting opiates. And there are studies to show that neuraxial long-acting opiates are superior to fascial plane blocks, but if you can't use them, then try to incorporate that. And then different surgical techniques can minimize post-op C-section pain. I'm not going to go into these. And then lastly, considering alternative things like TENS units and things like that. So that's what I have. Thank you for your attention.
Afternoon, everyone. I think we've had some great talks the past couple of days, and I like these little snap sessions. I think it gives us little tidbits that we can digest without losing attention in a longer talk. So I'm going to stick to some really basic cardiac stuff that's come out that I think may be broadly applicable. There's a lot of cardiac literature that comes out every year, but we put an article in JCVA, which is basically very similar to this, a year and update, and I just tried to pull some articles from there that I thought were of interest. I have no disclosures. The learning objectives, I think, are obvious. We're going to just review some of the literature like I discussed, and we're going to talk about some of the future areas of research. When I think about cardiac anesthesia, I think of a host of domains. We're going to just stick to 3 that I think are ones that I have done research in and I care for myself, but there's a lot of different domains within cardiac anesthesia. The 3 we're going to talk about today are transfusion medicine. We're going to talk about mechanical support and bypass management. We're just going to talk a little bit about some papers that came out discussing cardiac medicine itself. So transfusion medicine is what I am most interested in. It's probably what most of the papers that we've put out at the University of Miami are related to. This is not a paper we put out, but this is a paper in anesthesiology. It is noting a device. I'm not here to support this device. I have no affiliation with this device. But essentially what this is a feasibility study where they took 50 patients and they looked at cell salvaging techniques where they can actually salvage not only red blood cells but platelets. I think this is important. It's broadly applicable to a host of surgical subspecialties. It's particularly important in cardiac anesthesia. As you know, dilutional coagulopathy with the pump runs and the bypass machines is a big problem that we deal with in cardiac anesthesia. And if we're able to salvage the platelets, it would make sense to give them back to patients. And they were able to show a significant platelet increase. They actually did some functional assays on the platelets or on the patients, and were able to demonstrate the salvaged platelets actually had good function too. So that is promising. This is not a device that's on the market, but I imagine there will be several of these life science companies trying to develop this product. This is something we put out this year. We're looking at, we had an issue at the University of Miami. I think maybe a lot of people were dealing with this, where we're running out of protamine. We have a pretty busy surgical practice. We do about 1,000 cases a year. And this was particularly problematic for us. For one, you know, if we ran out of protamine, which I have coined, I don't know, maybe someone else came up with it, but we called it at UM anyway, a critical access medication, meaning there is no alternative agent. You run out of protamine, people don't get heart surgery. So there was a lot of interest in conserving our protamine, and we're one of the busier centers in Miami-Dade, so it would limit access to the residents of the Miami-Dade community if we were not able to do cardiac surgery. So we started giving everyone a single vial of protamine. It happens to be manufactured in 50 milligrams and 250 milligram vials. So we just gave everyone a single 250 milligram vial regardless of their heparin dose. Now, a lot of centers have HepCon and or maybe they use some more nuanced ways of dosing protamine, but we're still old school and do the whole ratio-based 1-to-1 deal. So we just gave everyone 250. You got 40,000 units of heparin, you got a 250 milligram vial of protamine. 50,000 units of heparin, you got a 250 milligram vial of protamine. And it's just how we did it. And anecdotally, it worked. So we went back, we did an investigation retrospectively, over 400 patients, and there was no difference in any of the meaningful outcomes that you would be concerned about. So we actually went and did a randomized blinded trial doing something very similar, which we're about to publish the data on, and it's the same. And what we were able to show is that by not doing this ratio-based system, we were able to conserve about 1.8 or 2 vials of protamine per patient, which if you are doing, 20 or 30 hearts a week, that's a lot more patients you can operate on by conserving protamine. Fortunately, we don't have a protamine shortage anymore, but we have changed our practice because of it. So this is something else we put out, but there's several people that have published on this. We started having a lot of patients showing up on these SLG2 inhibitors for heart failure management. The cardiologists are putting them on. There's a lot of emphasis on Ozempic right now, which has similar issues, and we need to, you need to stop it before surgery. But the issue we were finding with the SLG2 inhibitors was not, aspiration related, but was this euglycemic diabetic ketoacidosis. So we went back and looked at a group of patients that showed up without having interruption in their SLG2 inhibitors, and up to 20% of them actually did have evidence of euglycemic diabetic ketoacidosis, which I think just emphasizes the need that when you're taking care of these cardiac patients, even outside of a cardiac OR, we need to be aware there is a recommendation to stop them. And if we don't stop them, they are at risk for developing this euglycemic diabetic ketoacidosis. This is another paper that came out. This is pretty cardiac heavy. It's pretty only applicable in a cardiac operating room, but it's of interest if you take care of those patients and you're an imager and you do a lot of echocardiography. As you know, there's a large group of patients that show up for mitral disease or coronary disease who have concomitant tricuspid regurgitation, and there's always a big question mark as to what to do with those patients. Should you do an annuloplasty? Should you not do an annuloplasty? This is a paper that was randomized just looking at patients showing up for mitral disease that had either moderate or less tricuspid regurgitation with measurable annular dilation, and they were randomized to a tricuspid annuloplasty or no tricuspid annuloplasty. And the ones that got a tricuspid annuloplasty had less progression at 2-year follow-up of their TR and improved 2-year outcomes, which really argues that if you're going to be opening the chambers for whatever reason, say a mitral case, and you find moderate or less TR with annular dilation, the right thing to do is probably do a tricuspid annuloplasty. I think a lot of surgeons do that now, but not all of them. This is a paper I put in here because I think it has practice implications for all of us, not just cardiac anesthesiologists. It's something our own group, and I imagine everyone in here has some anecdote with dealing with, being stretched thin, if you will. This is just a paper put out in the American Journal of Cardiology, which essentially was advocating for retrospective analysis, advocating for the use of Impella in high-risk PCIs. What happens when these things get published and they get presented at national meetings, as you know, everyone sort of jumps on board, and then they want to do Impella PCIs, and then maybe they want to do Impella-insisted high-risk EP cases, and the application becomes endless. And a lot of these require some imaging support or some physiology knowledge related to mechanical devices. So then they're approaching the cardiac anesthesia groups to try and support these services. We already have had to carve out a group of us that are not necessarily cardiac trained or echo boarded that will do some of these high-risk EP cases or Impella guided PCIs, because we just don't have the bandwidth in our cardiac anesthesia group to provide those services. And sort of the request for services, I'm sure everyone's experienced this, is kind of endless. We're even starting to get asked to do, the appendage rule-outs for all the EP cases, which is just impossible for us to allocate staff to do all that. So anyway, this I think has implications on practice models. And this is just the last paper I'll talk about. I think this is kind of the hot topic. We actually heard Dr. Gruss talking about this a little bit yesterday. And this is just predictive models in medicine, you know, AI, all those hot buzzwords. If you do a Google Scholar search right now on your phone and you type in AI and cardiac anesthesia, there's like over 1,000 papers in 2023. I'm sure not all of them are high quality, but nonetheless, there's a lot of interest in this. And so this was a paper put in anesthesiology where they were taking parameters from the EMR and using waveform data, you know, pulse ox, A-line data, to predict ICU deterioration. And I think you heard Dr. Gruss talking about predictive models for hypotension. And I didn't put this disclosure in here because it's not applicable to this talk, but I did do some consulting work some years ago for a company looking at one of these predictive devices that they wanted to develop. And I will just tell you, I agree with Dr. Gruss when he said, you know, I'm always a little leery when they have a proprietary software they're not willing to share with you. And I will tell you, being on sort of the front end of helping try to develop one of these products, that the data that goes into it is often dependent, I know this may sound obvious, on how reliable that is. Or said another way, sometimes even a small missing piece, say the predictive model requires urine output, but your particular institution doesn't record urine output continuously. It can still give you a prediction, but the accuracy of that prediction changes. And I think as we get these predictive models out and they start finding their way into practice, like Edwards, HPI device, et cetera, the onus is kind of on us to understand the limitations and what is going into these predictive models and how to apply them to our patient groups and make good decision making. So anyway, that's it for the cardiac update. I hope that was brief enough. All right, thank you.
I'm Jess Geller. I'm going to give you pediatric anesthesia updates from the literature this past year. And start with disclosures. I don't have any. We're going to look at a couple of the top published articles in pediatric anesthesiology, and let's talk about the considerations and the future impact for pediatric anesthesia or caring for pediatric patients. This is a nice graphic. This is half of it because I like us to be able to see all of the facets that are in here. But essentially, one of the big buzz topics that's in pediatric anesthesiology since the early 2010s has been, what is the impact of exposure of anesthesia to the neurodevelopmental outcomes of very small patients? There's a couple of big trials that were conducted, and they are ongoing. The first one being in 2016. It's called the GAS trial, which was looking at the neurodevelopmental outcomes after general anesthesia and awake regional anesthesia for hernia repair. And so what they did is they looked at patients over the age of 26 weeks post-conceptual age, and then they monitored them after a short anesthetic, and that brief anesthetic was defined as around about an hour or less. And then they looked at neurocognitive outcomes, and they then had a follow-up study for the same GAS trial in 2019, looking at those same patients at 5 years. And what they determined was that there wasn't any significant neurodevelopmental difference with that brief anesthetic exposure after having, and they defined that as not having greater than a 5-point difference in IQ is an example. So when we're looking at that, there are many different other studies that have come across, and there's actually, in the Society of Pediatric Anesthesia conferences, we've had some really great pro-con debates about whether this is really a thing or not, because they have used animal and human models in tracking whether there is certain types of anesthetics and exposures that could have an impact and a negative impact. It is a question I do get very often in the perioperative realm. Is this going to harm my child? Should I wait longer before I get this corrected if it's not acute? Am I putting my kid at undue risk? And it actually has been one of the driving factors to increase the use of neonatal and infant spinal anesthesia for smaller cases below the umbilicus that are under an hour. And that has actually really taken off, and one of the reasons that we do cite is while we don't believe that there is any true evidence that there is a impact on neurodevelopmental outcome if there may be doing a neuraxial anesthetic where they are awake and we do a spinal and they don't feel anything. It's kind of beautiful. It's a separate topic to talk about. We will not be exposing them to anything during this period of rapid neurodevelopment. That being said, there was a couple of different papers that continue on this study, and with that, they are looking at, anyway, you can make mine bigger. I got my glasses on, I still can't see it. Okay, so as they were looking at those, I was citing those prior studies, in this recent article in 2023, they tried to look at cardiac surgery for congenital heart defects, and they wanted to look thereafter at 18 months of age and then look to see if that had any impact, given that especially neurodevelopmental disability is the most common complication after congenital heart surgery. And so what they did is they looked at medication class, and they looked at a Bailey 3 model that has 5 different facets to it. You have motor, language, cognitive, and then they also have a social, emotional, and an adaptive, but they didn't include those last 2. And then when they looked afterwards, they looked at the exposures of these different types of anesthetics and what their impact was on these 3 facets of the Bailey model, where you're assessing these, and this particular model is used between 1 and 42 months of age, and it's for infants and toddler development assessment. So as they were looking at it, they looked at a combination of exposure to volatile anesthetics, opioids, benzodiazepines, dexmedetomidine, and ketamine, all very frequently used for congenital heart surgery repair. And they were also looking at patients that were having that repair under the age of 4 weeks post-conceptual age, well, post-gestational age, so in the neonatal period. And during that time, so it was less than 44 weeks, and they also had exclusion criteria where they excluded those with genetic syndromes, those that had known other major anomalies that were non-cardiac, and then they also excluded those that didn't have English as a primary language. And then they classified the different cardiac cases for the level of severity of the case between class 1 and class 4, and that went from a tetralogy of Fallot repair, and class 4 would be your hyperplastic left heart syndrome type patient. And the most interesting part of these outcomes is that they started looking at that preclinical data did say that exposure to anesthetics in the early prenatal period can induce lasting impairment, that is I think in the animal models, but that children with congenital cardiac abnormalities undergo prolonged diagnostic and surgical procedures, and they require multiple anesthetic exposures, sometimes for very, very long hours. I've seen some take up to 24 hours. What they looked at is how can we demonstrate at 18 months of age in this same conversation whether there is any impact of these particular agents, and the only one that had an impact that was negative was ketamine. The others at 18 months of age had no difference whatsoever. So I thought that was quite interesting, because in the pediatric population, this is a question you get all the time, kind of like after the unfortunate early passing of Michael Jackson, and we got questions about whether propofol was going to harm everybody, and they didn't want the Michael Jackson medication. But this will be ongoing research that will be conducted, because if you can delay surgery, cardiac surgery is not one you can delay, then being able to use other methods or delaying would be something people would seek to recommend. So in the other vein of pediatric anesthesia, there has been a lot of fervor in the last 5 years or so talking about NPO guidelines. And I know you've heard about it on the adult side too, and in pediatrics it is especially important topic, and there has been a lot of really passionate changes that have been recommended in Europe. And a lot of the different studies that they were presenting in really healthy ASA 1 and 2s, as they were looking at maybe recommending adjustments to those guidelines, They recommended that we can adjust it back to maybe 1 hour for clear liquids and decreasing the other commensurately by 1 hour. But this year, our ASA pre-op fasting guidelines that had previously been updated in 2017, they went back and reaffirmed they felt that the literature didn't support doing anything earlier than 2 hours for clears. There was no real big benefit to having carbohydrate or protein-containing clears versus non-protein-containing clears. As we know with ERAS protocols, those can be recommended. The new updates included not delaying after somebody has gum chewing. I even remember when I rotated in Europe, that was a 2-hour delay. They said just make sure you visibly see them remove the piece of gum and proceed as usual. No delay is recommended, so that is an update there. And they did reaffirm that the incident of pulmonary aspiration following our guidelines currently is 0.020 to 0.13%. And so with all of these taken into account, on the pediatric side, they also said that delaying their ability to have their clear liquids all the way up until 2 hours prior, especially when you have shifts in when they're going to get their cases done, is not recommended. So avoiding prolonged fasting in children is added to the guidelines. So when we're looking at some of the other papers that concomitantly were added this year, this particular one is looking at ultrasound assessment of gastric fluid volume in children scheduled for elective surgery, and they administered 50 milliliters of apple juice in ASA 1 and 2 patients that were getting an otherwise non-endoscopy type elective procedure. And then they were able to ultrasound their, in the lateral decubitus position and measure their gastric contents, and they were looking to see what the difference would be between waiting 1 hour and 2 hours after receiving 50 milliliters of fluids. And so they wanted to answer the question, is the gastric fluid volume higher after 1 hour compared to 2? And they did find that the clear liquid administration of 3 milliliters per kilo, which was max of 150 but averaged 50, did result in a higher gastric volume after antral grade 2 ultrasound assessment compared to the 2-hour fasting. And so thereafter they said, we don't know if we really would recommend you reducing it to 1 hour. And this is in response to these multiple different studies and recommendations coming out by our European colleagues. So when they looked at this is a male 7-year-old in the 2-hour group, they were able to demonstrate that there was an empty antrum in 2 positions. And in this one is a 7-year-old in the 1-hour group, and they were able to measure and then use weight-based calculations. And they used a cutoff. The original cutoff has been about a 0.8 milliliter per kilo volume threshold to reduce the incidence of aspiration in any patient. And they suggested that they would look to see up to 1.5 milliliters per kilo, but they never found anybody that had greater than 1.5 milliliters per kilo. And so they said it's hard to know right now exactly what the threshold is, but we found a 30% increase in gastric volume using an ultrasound technique. They gave it to the patients awake. They measured them awake in the lateral decubitus position. So looking at the highlights, adding into this equation, there's one way to look at it. You can have somebody report. You can look with an ultrasound. Well, what happens when you go in with an endoscope? Can you measure better using an endoscope? And so this particular paper that came out was looking at preoperative clear fluid fasting and endoscopy measured gastric fluid volume in children. They had them follow our ASA guidelines for milk and for clear liquids. And with that, they measured them with the clear liquid fasting time between 1 and 18 hours. And the most impressive part is that no matter which patient they used endoscopy to suck out the volume afterwards, it still averaged only a 5 ml difference between the people that had it 2 hours ago and 18 hours ago, which was quite interesting. So while they previously said it was 0.4 to 0.8 milliliters per kilo, that was the threshold above which you're starting to risk pulmonary aspiration, they said that based on these ultrasound findings that they don't know, maybe we could consider reducing it from 2 hours. This is looking at the residual gastric volume over the fluid fasting time. You see, while it trends down with the x-axis being the fluid fasting time, you see a lot of different outliers in there. They looked and they said they had very specific conditions like celiac disease and other things. But as they went across, they said we weren't seeing any impressive difference. This one is looking between the child's weight and the residual volume. So you see it was concordant with as their weight increased, their volume did. And so looking at having the preoperative clear fluid fasting and measuring with endoscopy, they determined that maybe we need some more studies. But I thought it was quite interesting that first we have people very vehemently against changing the guidelines. That is what the ASA affirmed, that our guidelines remain the same. They just recommend making sure you go all the way up to the 2 hours before for pediatrics, and then don't cancel for chewing gum, and just make sure you watch them get it out of their mouth because they're a foreign body in the airway. But the other piece is that I think we don't talk about as often. How many people take care of kids on a regular basis? I mean, I exclusively do, but we take care of kids. Okay. So people say, oh, we need to wait this amount. They had a sip of water or whatever. I routinely order oral midazolam, oxycodone, acetaminophen, ibuprofen, and all of them are suspensions of particulate. I've seen before I've given them 30 mils of something, and sometimes, oh, quick, hurry up, get them back, and it's less than 30 minutes before they've received that. So saying that they sucked on a lozenge and we're going to have to wait 2 hours really just seems slightly off-kilter to taking into consideration that we're trying to preemptively provide analgesia and anxiolysis. Those are particulate. If they were to aspirate those, there are considerations there too. But I do think this conversation will continue, and my prediction is that there will come a time that we'll be able to do it in less than an hour, like less than 2 hours, but I think the consensus is out at this point, and we're going to remain conservative and lean on our ASA guidelines for NPO.
If y'all can even see me back here, I feel like I'm hiding behind this giant thing. But guys, I'm Ashley Bailey-Klassen. I'm going to give the update on interventional pain management. So Dr. Gerler and I were actually talking last night that there are way too many papers for me to decide to present from. Especially in pain, because pain in my world is changing rapidly. So I'm going to go through some of the more interesting publications from the last year. I'm also going to speak a little bit off my slides today because stuff has even come out in the last month that I wasn't able to get into the slide deck that's worth mentioning. I do have some disclosures that I have to present. None of it's relevant to what I'm speaking on today, however. So my learning objectives are really easy. Oh, they're switching up here. It's not switching up here. I apologize. There we go. There's my disclosures. My learning objectives today are really easy. We're just going to go over some of the more recent literature. However, I'm going to make this a bit of an active session. I've done some research recently. Learners learn better when they're lectured to, but when there's also some active learning involved. So while I am going to give you guys some best practices today, I'm also going to highlight some papers that I want y'all to go back and read, at least if you're interested in interventional pain. So first, let's get some of the regular stuff out of the way. CDC came out in November of last year with some updated clinical guidelines for opioid prescribing. My first couple of bullet points here is actually taken directly from the paper. That's why I have them in parentheses. They suggest failing all conservative therapies before you move on to opioid medications, including all non-opioid medications. They highlight that opioids should only be used when benefits for pain and improvements in function are expected to outweigh the risks, and you must discuss those risks with the individual patients. Of note, this does exclude pain management related to sickle cell disease, cancer-related pain treatment, palliative care, or end-of-life care. One thing to highlight in the CDC guidelines, they don't actually give an MME recommendations or MME recommendations that primary care has to do versus pain management. So I thought that was interesting. So I found this paper really interesting in my review. I have actually seen this in my own practice With the incidence of COVID, we're seeing newer and honestly very strange pain complaints. The most common symptom of what we term long COVID is actually pain, but also this whole conglomerate of just odd symptoms. Then the authors did note that there's an incidence of both new onset pain in patients post-COVID who had never had pain complaints before, but also a worsening of patients who had a pre-existing chronic pain. I'm going to take a little deviation here. When we're talking about odd pain complaints in my world, painful diabetic neuropathy is something that pain physicians are now seeing more and more of. A paper that, Dr. Peterson has done multiple studies on some high-frequency spinal cord stimulation to treat painful diabetic neuropathy. Beginning of last month, she came out actually with some 24-month data that shows now we're returning sensory function. So 65% of patients at 24 months actually had a noted regrowth of sensory function. So for the first time in pain management, we actually have a disease-modifying therapy. Like I said, I didn't even have time to get that in this PowerPoint, but I wanted to at least mention it because it was some pretty good data. This is one of the ones I want you guys to go and read up on. So the American Society of Pain and Neuroscience has started this best practices guidelines series, really, but this is the one on low back pain. It is a very large meta-analysis of comprehensive interventional treatments for low back pain. What I want to highlight on this, and one thing I love about all of these, is it's multi-specialty. So we're really reaching across the divide. It's with our surgery colleagues to come up with best practices and best guidelines on the ways to treat pain. So comprehensive clinical guidelines, all based on evidence. Another thing that I want to highlight on this, Dr. Lee has an amazing one also on guidelines for radiofrequency ablation. So both of those are papers that are actually continuing to be updated. This one for low back pain came out in December, but they've already had updates to it. So these will be continually updated as we move forward. So this is my oldest paper. It's just over a year old at May of last year, 2022. But the reason I wanted to highlight it is I was hoping to be able to present some data that was presented back in July at one of our major pain meetings. So this is a secure study. It was based on a posterior SI joint stabilization device compared to the more traditional lateral approach. So the 6-month data that I'm presenting was based on the first 69 consecutive patients. The 12-month data that was presented in July did fill out to the full 100. Very few adverse events related to the device compared to 17 related to the lateral approach. Good reduction in VAS as well as improvement in functionality based on their ODI. But the 12-month data, what I thought was interesting is when we go back and pool some of the other data included in this, the posterior approach shows a much better safety profile included in length of hospital stay, length of anesthesia duration, so that's important for our world, massive decrease in blood loss, and a decrease in M&M overall posterior versus a lateral approach. So again, this is kind of a mix of data presented last year, or published last year, but presented in July. This is kind of a similar slide. So there's actually two different papers kind of highlighted on this slide. A paper that was published in August of this year and then some data that was presented again in July of this year. So this is a novel approach to a lumbar interspinous fixation device coming from a lateral approach. The first part of this study, they were looking at actual fusion or stabilization rates in this with this device. And based on 3 independent radiologists out of 69 total levels, 93% had a fusion rate at about a year out. The other part of this study was based on safety and efficacy. So they took 202 implants based out of 191 patients, all with interventional pain physicians. So these are interventionally pain docs doing a lateral approach to a lumbar interspinous fusion. They showed a great improvement in their NRS scores and almost no adverse related events. None of them were actually related to the procedure. The REFINE study is a very similar type of study. This is actually a posterior approach to an interspinous device. Again, this is data that was published in February of this year. They just came out with 6 months data. That's a white paper that's accepted for publication but not currently in print as of yet. It does flesh out these same numbers here. Only one adverse event, no complications prolonged secondary to the device itself. And again, this was done with interventional pain physicians. what I like about both of these last studies, even though the physicians performing the studies were interventional pain, again, it was a multi-specialty groups. So both surgeons and pain physicians were collaborating for this data. This one was a prospective study. The other one was retrospective, looking back at some patients who had already been implanted. And again, both of these are being fleshed out further as we follow these patients along. So I tried to be short. I tried to be quick. These are all my references. If you guys have any questions, please feel free to track me down.
Good afternoon, everybody. I'll also try to be short and quick. This is the new ASA 2023 practice guidelines for neuromuscular monitoring. And I have no conflicts of interest and no disclosures. And also, these are my learning objectives. Discuss the 8 evidence-based recommendations from the guidelines about management of neuromuscular monitoring and antagonism of neuromuscular blocking drugs during and after general anesthesia, and understand the factors which contributes to the high incidence of residual paralysis or weakness, and how to implement these recommendations. There are omissions, sorry. What happened? Here we go. There are omissions to the guidelines, and it is not meant to use in a difficult airway situation. It is not to address blockade usage to optimize intubation or surgical conditions. And then the ASA guidelines are not intended as standards of care also. So it is these recommendations may be adopted, modified, or rejected according to local institution needs. And there are frequent incidents of residual blockade at the end of the surgery in the PACU. Actually, it is as high as 64% of the patient. The result is result in the inadequate recovery from the effects of the paralytics. These causes upper airway obstruction, reintubation, atelectasis, pneumonia, prolonged stay in the PACU, and also decreased patient satisfaction. So there is also convincing evidence that preventing their occurrence leads to improved outcomes. There are 3 types of monitoring that's talked about in the guideline. The clinical assessment, which is the head lift, hand grip, and fade. Qualitative assessment, which is using the peripheral nerve simulator and the train of 4. And then the quantitative monitoring. There are 3 types of quantitative monitoring that's discussed further in the guidelines. That is acceleromyography, electromyography, and mechanical myography. Both the ASA and the European Society, both guidelines strongly recommend using quantitative monitoring now rather than the qualitative assessment, and to confirm that we have a train of 4 ratio greater than equal to 0.9 prior to extubating the patient. The type of antagonist they also recommended use is Shugamidex over rather than neostigmine for patients who have received rocuronium or bacuronium and who have residual block at or deeper than a train of 4 ratio of 0.4. If in case one of the clinicians need to use neostigmine, they recommend only to use neostigmine when during minimal depth of blockade, which is a train of 4 ratio of 0.4 to 0.9. I know Dr. Suzanne Hufnagel talked about the obstetrics. This guideline didn't talk about any obstetrics patient population. There are the benefits for quantitative monitoring in this slide. Again, there's decreased mortality, decreased length of stay in the PACU, and increased patient satisfaction. Currently, quantitative monitors are infrequently available. Peripheral nerve simulators are used in less than 50% of anesthetics with paralytics. Many clinicians continue to use clinical indicators such as sustained head lift to guide their decision on when to extubate the patients. Clinical tests are not sensitive to detect residual blockade, and clinical tests are not applicable to patients, especially under the influence of general anesthesia. So this is why we need reliable information prior to extubating our patients safely. What are the factors leading to high incidence of residual blockade? There's variability in the duration of action of the blockers, and then there's a mistaken belief that the 4 visibly equal twitches to train of 4 simulations and sustained tetanus indicate a full recovery. And then people also use clinical assessments such as respiratory measures of tidal volume, head lift, hand grip. And then there is also using FADE. FADE is not reliable until the train of 4 ratio is less than 0.4, and according to quantitative monitoring, 0.4 is less than minimal blockade. And then the lack of fade is also represents the broad range of ratios from 0.4 to 1. There's also the depth of blockade and pharmacologic antagonism is not yet well understood by many clinicians. So both the drug chosen and the dose given is dependent on the accurate assessment of the depth of neuromuscular blockade. All of these results in clinicians using fixed dose and blind antagonism, such as using 5 milligrams of neostigmine or 200 milligrams of Aoca Gs without accurate assessment. And this leads to potential adverse effects. Why the slow adoption is despite multiple studies showing benefits of quantitative monitoring for over 50 years, a 2019 international survey identifies because there is overconfidence in the assessment of blockade, underappreciation of the frequency of residual blockade and its consequences, and a lack of commercially available quantitative train of 4 monitors that are user-friendly and that are inexpensive. Fortunately, currently there are recent improvements in the technology. These are the 8 recommendations in the guidelines. So 6 of the recommendations were classified as strong recommendations with moderate strength of evidence per the grade classification, and the 2 in the bottom, 7 and 8, were classified as conditional recommendations. Strong recommendations reflect the task force believing that almost all clinicians would choose the specific action or approach. And conditional recommendations are those where most but not all clinicians would choose the action or approach. There's 2 that I'd like to mention also. That the task force recommend against using the eye muscles for neuromuscular monitoring due to the resistance of the eye muscles. And when the eye muscles are used to monitor, this can lead to neuromuscular blocker overdose. And also when using cis-atracurium or atracurium, this can only be antagonized with acetylcholine esterase inhibitors, which is neostigmine, due to the fact that they are ineffective. The Aoca Gs is ineffective. I'll skip that also. When Aoca Gs was used and a train of 4 ratio greater than or equal to 0.9 was confirmed before extubation, the incidence of residual blockade was only 0.5%. If a train of 4 ratio was not confirmed prior to extubation, then the incidence was 2.2%. Now compare this to when neostigmine is used. The incidence rises to 5.3% with confirmation of a train of 4 ratio, and 44.9% without confirmation of train of 4 ratio. The guidelines provides definition of depth of blockade also. If you go over the guidelines, sometimes it's the depth of blockade are classified as complete, deep, moderate, shallow, minimal, and acceptable recovery. For the timing here, I'll go over the acceptable recovery and minimal depth of blockade. Acceptable recovery it cannot be determined with our qualitative or peripheral nerve simulator. But with using a train of 4 ratio, acceptable recovery is greater than equal to 0.9 with the quantitative monitoring, and this is defined as being able to extubate the patient safely. Minimal blockade is when it's defined as a train of 4 count of equals to 4 without a fade, and this is when using a peripheral nerve simulator, and a ratio of 0.4 to 0.9 using the quantitative monitor. So regarding the antagonists, which to use, sugammadex or neostigmine, the task force recommends that when the quantitative monitoring is not available, and to be relatively sure that the block is adequately recovered, a minimum of 10 minutes should pass if neostigmine is used before extubation, or sometimes even longer if the patient is even has a deeper blockade. Regarding the adverse effects between sugammadex and neostigmine, 10 randomized controlled trials had shown that there's a lower incidence for sugammadex, and also in regard to residual blockade, and also the time to train of 4 ratio greater than or equal to 0.9 was shorter in patients antagonized with sugammadex. The guideline also talked about dosing of sugammadex and neostigmine. Regarding dosing of the sugammadex, is dosed based on train of 4 ratios or train of 4 count. When neostigmine is used at minimal blockade, the dose should not exceed 40 mics per kg. The shallower the blockade, the lower the dose required. This is because higher doses may have paradoxical effect of causing weakness, and neostigmine with neostigmine, when a dose exceeding 30 mics per kg is given after spontaneous recovery, which is defined as train of 4 ratio greater than equal to 0.9. For succinylcholine, in the task force also suggests that if in case you see clinical signs of delayed recovery from succinylcholine, they also recommend using the neuromuscular monitoring to guide prior to extubation. Which is in this case of a train of 4 ratio with quantitative monitoring of greater than equal to 0.9 is safer. And the last is the guideline talked about how to give guidance to local implementation. We should provide education, select a champion, define indications and contraindications, do quantitative monitoring, decide which manufacturer to use for the device, ensure the monitors are readily available to everyone, and promote the results, positive results regarding increased patient satisfaction, decreased length of stay, decreased post-op and pulmonary complications. So guidelines, conclusion is guidelines are not standard. For women using hormonal contraceptive, this was already talked about in previous lecture, receiving sugammadex, the FDA labeling states to talk to them about a backup contraception method for 7 days. And occurrence of residual blockade is affected by the appropriate use of antagonist drugs and monitoring of equipment. Spontaneous recovery is also spontaneous recovery of train of 4 ratio greater than or equal to 0.9 with quantitative monitoring do not require antagonism. Thank you.